Oh, I can see some beautiful artwork there by one of our families. I'll try not to get distracted by looking at the families on the screen. So as Hayley said, I am from the Murdoch Children's Research Institute down here in Melbourne in Australia. So thank goodness for telehealth and email and the ways that we can connect together, because of course being a rare condition, it was really important to try and reach out and capture everybody to include as many people as possible. And so thanks again for making this possible. But really, what do you want to know? What do families want to know? And what do clinicians need to know as well in order to best support the development of your children? Well, you want to know how and when will speech and language develop. Often you want to know what factors will affect speech and language development, and what areas do you want to target in therapy. I think a really core area, and we might have some questions around that today, which I'm really welcome and will be pleased to talk about. But I thought it's helpful even to first define speech and language, because I know we often use the terms interchangeably until you go and study speech therapy, and then we start to talk about them a little bit differently. So in terms of speech, the way that speech pathologists define speech is around the perception, so how you sort of hear and perceive, or how you produce individual sounds. So a t, a k, a g, or whatever your native language may be, that the core individual sounds that make up your language. And that's often called phonology or phonemes, the very smallest parts of speech. And that's what we mean when we say speech. Whereas for language, we're really more talking about word use, sentence use, and understanding. So if you like your vocabulary, how many words do you understand when they're said to you, and how many words do you then use when you're speaking? And grammar, do you put the words in the right order when you're talking? When someone asks you a question, do you understand how those words are put together to understand the meaning of the question? So when I talk about speech today versus language, that's the way that we have just defined them for this study. So to go a little bit deeper, with speech, these are some terms that might be familiar to you. So we have articulation, and often articulation is used as an alternative word to speech. But again, when speech pathologists, or speechies as we call us, start to listen and define categories of speech, articulation really is more around a few sounds that might be a little bit imprecise. So a lisp is a core example of what we mean when we might say an articulation difficulty. Whereas a phonological disorder or phonological problem means that you're not understanding the use of individual sounds in your language. So for example, a child might transpose, or if you like, swap around different sounds. So that's where you might have tat for cat, for example. Okay, so children are using a t to replace the k in this instance. Then we have fluency or stuttering, which I think is quite an easy to understand condition. I believe that the current running president, I think you're very close, actually I haven't checked this morning, I should have checked that, but never mind, you'll tell me later. Joe Biden experiences disfluency or stuttering. And then we have childhood apraxia of speech, or dyspraxia or speech apraxia, which are different terms that are used. And some of you might be familiar with this condition. So in apraxia, you have a few core features. So with apraxia, it's thought to be a condition where you might know the word that you'd like to say, but then getting your lips and tongue and voice to coordinate, putting those sounds in the right order and doing that right every time, correctly every time, and also having the right pattern, the right sing-song, if you like, or prosodic pattern to your speech. When all of these features don't come together nicely, that is apraxia of speech. So some core features are, if you ask a child to say the same word 3 times, they might have trouble assembling, putting all those sounds together and having the right pattern each of those times. You might see different errors each time. So that's one example of apraxia. The other example is when children are quite non-verbal and are still trying to learn their sounds. And as some children pick up sounds very easily, children with childhood apraxia of speech might need multiple repetitions. And that's different from a phonological disorder, because children who have just phonological problems tend to be able to develop their speech and they're able to chat away very, not effortfully, but they just swap their sounds around. But what often happens is we have a combination of different speech conditions that are coming together. And I'll talk more about this as we discuss the results of our study. And then the last condition I have here is dysarthria. And dysarthria is where, again, the child knows the words they'd like to say. They don't have problems assembling the sounds together. The sounds are in the correct sequence, but when they produce the words might be much slower and they might be quite imprecise. So the most common cause associated with dysarthria is in children who have cerebral palsy. And if you've met a child who has cerebral palsy, if you have that sort of picture in your mind of that presentation, that's a very good, clear example of where you have dysarthria occurring sort of more on its own usually. Those children tend to have more of a pure dysarthria. So I'm not saying that if our children have dysarthria, you have cerebral palsy. I'm not saying that. I'm just giving a nice example of trying to think about the imprecision you might find with dysarthria. It's where you don't have really good, clear neuromuscular or control, brain control and coordination of the lips and the tongue to produce your speech. So I know that's a lot of information and we can come back to that and we can ask more questions around this. But for some of you, you might have already received one of these diagnoses. And I'm always welcoming of emails to ask for more information or give you more definitions of these conditions if helpful. But your local treating speech pathologist, I'm sure, will have already introduced you to many of those terms. And then just to break language down a little bit more. Sorry, the sun's coming in here this morning, which is quite nice, but I might have to shut the blinds in a minute. So for language, we have receptive language, which is a term I'm going to use throughout the talk today. So receptive, what do we mean? It's comprehension, reception. So when we talk about receptive language, we can mean both your understanding of words or your understanding of vocabulary, your vocabulary, or again, your understanding of grammar. So your understanding of sentence structure, your understanding of use of plurals, use of word endings, past tense. Did you run or were you running? And then we have expressive language, which is easier to conceptualize. Again, that's your use of words, your use of vocabulary, your ability to produce sentences with correct grammar. And then we have social language. So are we making eye contact? Do we understand that I might say something in a conversation and then I should wait for you to have a turn? Do we understand providing context? So we don't just come up and say, oh yeah, Billy had that taco, yeah. And sort of, what was that about? Oh, that's a bit tangential. Have you told me? Well, when did Billy do that? Was that yesterday? Are you talking about at school today? Sort of understanding the rules of social language and thinking about the speaker, not just thinking about what message we might like to convey. So what we really want to know, what was the aim of our study? Well, of course, as you know, it was to better understand speech and language abilities of children with this CEPBP1 condition. So who did we recruit? Well, we had 31 individuals take part. We actually have a few other individuals who've also taken part, but they're more part of a separate study, which Maggie Wong and Breggia might talk about at another time. So I just wanted to say that because I guess really we sort of had about 36 people take part, which was fantastic. But in this speech and language focus study, we're going to talk about 31 individuals who kindly took part. So we had 11 males and 20 females who took part, and we had an average age of about 8 years, but a range in age of 1 to 14 years. And so we had individuals from the UK, United States, 12, the UK, 3, Canada, the Netherlands, quite a large number of cases. And that's again because they have, whilst they have a small population, less than Australia, only 18 million, that's nothing compared to the US, of course. In the Netherlands, they have amazing genetic resources and genetic diagnostic centres, and they have been doing so for many years. For many years, the government has funded exome sequencing, which has been fantastic for all of their patients. So that's why we have quite a good representation from the Netherlands. And of course, because they were some of our collaborators who also tried to recruit their families for the study. France, Israel and Australia. Here we're getting technical, and I'm not a molecular geneticist as a speech pathologist, but Maggie, one of my collaborators on this work, kindly put together all of the different variants, or if you like, the different spelling errors we have for individual participants within the SETBP1 gene. And so we can see here that we have some of you who might have already taken part in past research, but the majority of you who are taking part, your particular variant or the child's spelling error within SETBP1 has not been reported before. And that's really helpful for our research because the whole scientific community will learn more about where the different variants occur in the gene and whether there is a relationship between where your variant occurs and the presentation of speech and language, or the phenotype, as we call it, of the children. So, and the other reason is that in the scientific world, the journals are quite tough on us. If we just keep reporting the same individuals and same participants, they feel that you're not really adding more information, even though you might be focused on a different area of development. So that's just something to keep in mind. So you can see we've had a really great spread here. And a couple of individuals had very small deletions, and one individual had a larger deletion within chromosome 18 as well. So our method, I mean, this bit's a bit boring, but this is the hard work that you did, and it's boring to go over all of these surveys. But just to put into context, why did we do those, and to thank you again. So the Very Long Health Survey, that I know stretches the friendship very much, 22 pages or so, but online it probably felt longer, is so that we can really understand all of those factors, like we sort of said in one of the earlier slides. What are the other factors that might affect speech and language development? Is it, you know, sort of, do we have a lot of hearing loss, a lot of maybe some tone disruption that might affect muscle development and muscle use and muscle memory? Do we have visual difficulties that then might also mean it might be harder for children to process sounds and think about sounds as individual units as they're learning to read and write? So we asked you all of those very many questions so that we could really understand other factors that might be influencing speech and language development. So thank you for completing them. We then also looked at past clinical reports. Because we're only seeing a snapshot of development in time, it's really nice to see what other treating individuals who've seen you over time might have recorded, and how that your child's development might also have changed over time. So that, thank you for uploading those reports and sharing further videos with us. That's really helpful to help us feel that we understand your child and their development better. There was a tool called the Children's Communication Checklist that asked a little bit about language and a little bit about social skills as well, so that we could understand the two next to each other, if you like. People often say, well, is autism a big part of it? Because sometimes social skills are impaired. So that was a tool that helped to examine those features, which we'll talk about. There's a brief scale that looks at overall speech intelligibility. Can your child be understood all of the time, some of the time, etc.? I'll report on that today. There was another very long survey. I'm sorry about that one also. That survey looked at motor skills, daily living skills, and different behaviours. How does your child sort of adjust or adapt in everyday living to different conditions? And that's called the Vineland scale. And that scale is useful because it does give you motor information, movement information, versus social skills versus language. And you can then do a comparison to try and understand, is my child's movement development more affected than communication, or is social development more affected? So it sort of gives us understanding of relativity of your skill development. We focused on speech and language, but for some children, feeding difficulties can be significant. It doesn't seem to be as significant an area to be concerned about for children with SETBP1 disorder, but we only probed that with one brief tool, and not everybody might have received that tool, because if children were a little bit older, the tool's not very useful for children over 7. But I'd be interested if people do feel they are still experiencing feeding difficulties, because it might be interesting to think further about that and whether we could have measured that better. And then for many of you, we had a parent video interview. For some individuals where I might not have been able to speak the language and we couldn't organise a translator, we might not have met each other, but you might have shared videos. And I certainly know one family that had so much Zoom and telehealth during COVID, they were not keen for a teleconference, and I very much understood that. They were about to go off on a holiday, needed a very good break, one of our British families. So I could very much relate to that at the time that we were all in lockdown. So what did we find? Here are some of the co-occurring health and development challenges people were experiencing. Now this is called a radar plot, and in the centre is 0, so not occurring much, and then we sort of come out in 10% intervals, if you like. So here I've got anything that was greater than 50% occurring. So attention difficulties, or an actual diagnosis of ADHD, which we know can co-occur in SETBP1 condition, was actually only really noted in about 55% of individuals in this particular cohort. Sleep difficulties were also a feature, but we don't really understand how sleep and speech and language go together. So sleep difficulties have also been studied by Dr. Von Bon, who's running a separate study looking at all different aspects of development together. So I'm leaving the sleep out of our paper for Breggia to focus on. Here we see fine motor impairment, so thinking about handwriting, drawing, doing up your buttons, so sort of those fine motor skills. You can see that's a real challenge. So in around 90 or 80, 85% or so of individuals. And that's often fine motor challenges come hand in hand with apraxia of speech, actually, which we'll talk about as we go further. Gross motor impairments had still been very much present for many children too. So this is a little bit more, can you ride a bike? And many children could play sport and were great at running or might play soccer, etc. But when it came to more refined skills, skiing or bike riding, these kinds of things, children might have more difficulty with those learned gross motor impairment skills. Learning or cognitive difficulties or impairment was quite a core feature. But it ranged. I think one individual was typical and didn't have any learning difficulties in this way, but the majority of children were mildly impaired to moderately impaired. And then we had a couple of children who might have more involvement, more severe involvement of their learning abilities, and some other people who might have more borderline involvement. So certainly learning difficulties and the cognitive challenges were across the group, but in a continuum, from some who had less difficulty to some with greater difficulty. Receptive and expressive language impairment, we'll unpack that a little bit more as we go through, but you can see here again sort of 85 to 80% involvement with receptive and expressive language impairment. As I said earlier, thinking about some of the core factors that are generally thought to maybe have an impact on speech and language, are these having an impact in children with CEPBP1 disorder? Well, few children had hearing impairment actually. So 2 children had bilateral, so both the ears being involved or affected, if you like, but just mild loss in those ears, and mixed loss. That means you have the sensory neural hearing loss, plus also more a conductive loss. So the loss that you get when you just get a middle ear infection on top of some underlying sensory neural, more permanent loss. One child had a unilateral mild conductive loss. So that mild conductive loss, again, in some instances, conductive hearing can resolve, but for others, sometimes you can have impacts on the bones of the middle ear, or differences that mean that conductive loss is a little more permanent than the sorts of loss that you have when you just have a middle ear infection. And 2 of the 3 children wore hearing aids as well. But you can see here across the group, really hearing was less of a core feature. Vision, we know vision's often, vision issues are often present, and we see that for some of the children it was just farsightedness, and many of the children wore glasses, but nothing of really great concern. It's just a lot of children do need to wear glasses, and again, Bregia von Bonn is looking more at the specificity or the particular types of visual issues in her study. But for speech and language, we often don't think about ensuring that as we learn speech sounds, and as we're doing the early learning of the relevance of sounds for reading and writing, the importance of vision and sort of visual organisation, and being able to clearly see your letters and to write your letters in with the fine motor coordination, how important all of that sensory integration can be, and that feeds back into speech. Because also once children really understand individual speech sounds, they can help use those, the written form, as a strategy to help them organise and assemble sounds. So as the children get to that sort of reading age, and you're really supporting that development, it actually can then have a positive flow back effect to speech, something we don't think about very much. Okay, so what about other oral structural difficulties? Again, not a huge impact in children with CEPBP1 disorder, which is really nice to see. So only 1 or 2 children had sort of palatal abnormalities, so a repaired cleft palate in one child, and I think some mucus cleft in another. There might be very subtle features that might have been mentioned for some of the children by clinical geneticists in their report, but these aren't things that are anything to be concerned about. So perhaps a little bit thin lips, but we can see this in the general population. And some people reported a more of a narrow mouth, but again, that's all part of really the normal general variation across the population, and does not impact on speech and language ability. Micronathia, or if you have sort of a smaller type jaw, unless you have a malocclusion in that the jaw and the maxilla or the upper mouth aren't aligned, then there's not really ever a problem with this either. So the children seem to have good alignment of the upper and lower jaw, and that just helps us if you think about sounds like p or b, where you need to have your lips being able to close to produce those sounds, or even when the tongue's moving up to say t or k, you need to have nice alignment of the upper and lower jaw. And it's nice to report that this didn't seem to be a challenge for children with CEPBP1 disorder. Some of the children did have extra teeth or other orthodontic challenges, but not a huge amount of children. And of course, the general population of people without ZBP1 disorder, we also have these challenges. So it felt like there wasn't anything structural to be concerned about that would really be impacting on your speech, unless perhaps you did, of course, have a cleft that had to be repaired. But once the cleft was repaired, again, typically we can train the speech to be accurate and not be impacted by the structural difficulties. Feeding development, with early feeding development, certainly this was something that some individuals express difficulty with. Sometimes when you have real hypotonia or low tone, which was seen for some children in the early months of life, and for some ongoing, of course, that can impact on your feeding ability, hence why tube feeding might have been required. But not really huge numbers were reported, again, which was really quite positive. Moving on to managing solids or lumps with feeding, that can be quite a significant problem for many children, again in the general population, not just in children who might have a genetic or neurological challenge. So it wasn't surprising to see that a number of children had difficulty with this transition into lumps and solids. In terms of motor development, you'll be more familiar probably with these areas of development because they were more commonly seen. So we saw the gross motor delay or impairment difficulty, or formal diagnoses of developmental coordination disorder in 78% of the group. But only about 1 in 5 children were given that specific DCD diagnosis. And that specific DCD diagnosis doesn't often offer you much more than just knowing that you do have the gross motor impairment or delay or a fine motor impairment or delay. What is the point of the diagnosis? Well, the point of the diagnosis is to get you good support and treatment. And as long as you're already seeing an occupational therapist and or physiotherapist, fantastic. We don't worry so much about exactly what the specific diagnosis might be, as long as we're understanding where we need that help, where the difficulties are, and how to get that support. For many of the children, though, the specific type of movement or impairment or challenge was really around that planning or programming level, and that's the term dyspraxia that we often use. So we're talking about speech apraxia in a little while, but here, of course, we're talking about body apraxia or dyspraxia and movement dyspraxia, which is more at this planning or programming level. So just like I was saying for speech apraxia, where you know the words, but it's then the challenge of getting your body's ability to then sequence those sounds correctly and plan and program. Similarly for body dyspraxia, the child might sort of know the movement they want to make. They're desperate to ride their bike or they're desperate to write their name beautifully, but then their body is just not helping them plan and program to implement what they would like to do in the best way. And similarly, the fine motor impairment and delay, which really comes in with all of these areas as well. So you might have the whole body dyspraxia, and then also more specifically with those challenging fine motor skills, which are a higher level skill. And then speech motor impairment or delay in 86% of individuals, which we'll unpack a bit more in a moment when we talk more about specific speech diagnoses. We found that first words were delayed in some, or in the majority of children, I suppose, but some children had developed their first words around 12 months of age, which is when you typically do develop first words. And then talking in short sentences, this is something that many families are wondering, well, my child is getting there with first words, when might sentences come along? So sentences for many children occur at around 2 to 3 years of age in the general population, but for some of the children with ZBP1 disorder, they didn't come until 6 or 7 years, as we see here. So that's great to know, though, that there's still this great ongoing development. So we mightn't be there at 3 years, we mightn't be there at 4 years, but let's keep going because the systems are still developing and it just takes more time and we get there. Sometimes it feels like we're not going to, but we do. Okay, so that's very positive. Of course, for some families, children are still less verbal and might still just be at that stage of trying to develop words, or for some families, children were more non-verbal, so still really learning those first words. So for the specific diagnoses of speech that came out in the group, the majority of children had what could best be characterised as a childhood apraxia of speech, which we've talked about a little bit now going through. Now the percentages don't add up to 100, they're more than that, because many children had 1 or 2 diagnoses, and the most common diagnoses were apraxia of speech alongside phonological disorder. So they're the 2 core features that we saw. For some children, as I said, around 1 in 3 children were less verbal, so just having sort of less than 50 words we define minimally verbal as. Articulation, so some lisps and other specific features in precision on top of phonological disorder or apraxia in some of the children. 1 child had stuttering, and a proportion of the children had dysarthria as well. What tended to happen with the dysarthria was that children would largely resolve or improve in their speech apraxia, and then have just some dysarthric features that were present. So the intelligibility or accuracy of speech sounds improves, but then there is this underlying just imprecision. So they're getting the sounds right, the words are correct in the order of words. They might be getting short sentences where the specific sounds and words are correct, but the timing of speech is a little slower, and the precision of some of the sounds is a little less crisp and clear, a little less precise. So for many of the children, the profile, if you like, of development was early feeding difficulties for some, delayed first words, errors on vowels and consonants. So that's another difference. In phonological disorder, you're usually just talking about consonant changes. In apraxia, vowels are also affected. So that's a core diagnostic feature of where we see apraxia being different to phonology. Children were inconsistent. So as I said before, you might give them the word helicopter and you might say that 3 times. And each time a child might say something slightly different. So helitopa, heyopa, hepiopta, for example. Prosodic errors, so is the stress of or the sing-song nature of your speech, is that typical or is that altered? So for some of the children with apraxia, you might hear a bit more excess and equal stress, we call it. So putting more emphasis, or you might say banana or banana. So you're putting stress differently onto a word. And so sometimes children can understand where the stress should go, but again, they're not able to coordinate stress such that they get the right targets. And then, as I said, in some children, the dysarthria appears more apparent as the apraxia resolves. So as we can hear the child producing more speech, then you might hear a little bit of the dysarthria there. And why are all these things important? Well, you want to get the diagnosis right so that you then get the right targeted therapies. Okay, so in terms of speech intelligibility, here just 30 people completed this because one of the children were younger than 12 months and hadn't developed their words yet. But I guess for the majority of individuals, their child was sometimes able to be understood. For some, rarely, and for some, usually. So again, quite a spread across the group. Okay. Around language and literacy, on one of those assessments that we had, many children did have a receptive language difficulty, expressive language difficulty, and these varied in the rate of severity. Some children also had difficulty with social language, and we'll unpick some of those features in a little while, and also literacy difficulties, reading and writing. So most children, though, had their expressive language and receptive language at a similar level. So sometimes because speech is so difficult, we often think that expressive language is much worse, but actually with formal testing, receptive and expressive language did seem to be at a similar level. And that's important to think about because we still really need to work on our receptive language and comprehension and teach children the parts of grammar, teach children about plurals, teach children the order of how words go in a sentence for them to then be able to use those accurately. We often assume that, oh, they understand it, they just can't produce it. But actually we need to make sure they really are understanding language and the rules of language and giving them the ability to learn with the right structure. Some did though, 1 in 3 still did have poor expressive language than receptive language. And when you're talking about a severe or more challenging speech disorder alongside the language problems, that makes sense. And many children had difficulty copying their letters or writing their name, and we know that from the fine motor difficulties. But really, over time, older children, because of course we've got a spread of ages, oh sorry, my family are a bit loud there, although older children could write longer sentences. So again, it's that ongoing development, fantastic. Yes, it's really tricky and it takes us, our younger children, longer to get there, but they can get there. Really important to hold on to that when you're working so hard in therapy. Here's the test where I said we look at features of communication and then also social skill features. Interestingly, the children did have more difficulty across the communication features, so syntax or grammar, semantics or your understanding of vocabulary, and then coherence is what you're saying, making sense all together. These were areas of difficulty for the children. Whereas most of the social areas of social skill, they did really well, except for use of context, which was something I talked about earlier, that use of context. Oh, I've just come and said something or other to mum, but I didn't tell her when this happened or what really it was about. I just sort of said something a little bit random out of the blue. So that seemed to be a bit of a feature for some children. But it didn't mean they've got all these other social difficulties. Many of the children love to communicate, don't they? And they're very sociable. And we need to pinpoint how we can help them have more communication success and more successful social interactions. So probably talking about that use of context seemed to be one feature we could highlight. So certainly there are some social difficulties, social language difficulties, but to us it didn't feel that the profile was fitting with a very strong profile of autism. We didn't get that from looking at the language aspect. Now, I didn't study stereotypic behaviours or sensory issues and some of the other features. So if somebody were only looking for autism, maybe there are those features that are more common and you would be able to tell me that. But in terms of their language ability didn't really fit a profile of autism. Looking across movement, daily living skills, social skills, looking at them across here together, ABC, this is overall. If you put motor ability, social skills ability and communication ability all in together, and daily living skills, this is an overall rating. But here in the orange and green, yellow, we've split these features out. And you can see here communication compared to daily living skills, socialisation and motor skills, communication performance was a little lower, and that was statistically significantly different. So communication does seem to be, it's no surprise to you, quite a core feature for the children. But this is really important to tell the general literature and to put that in a publication to make sure you get that speech therapy funding and speech therapy report. It doesn't mean you don't also need support with other areas. And of course, we'll be advocating for support in all areas, but this was just quite an interesting feature. And scientists want to understand how SETBP1 works. And it does seem there's something about SETBP1 that really does, alter speech and language development and the trajectory of speech and language development. This is just saying that the scores, if we look a bit more deeply than just looking at those that figure before, the scores for communication were around 11 points lower on average than the other skills, okay? But that's a nice way around. I tell you, it's great to have those daily living skills. It's nice, isn't it, to have children who are quite seeking social engagement. This is all very positive. We just need to boost up the speech and language. So what do we learn all together? What do we take away? We want to always make sure that hearing is accounted for. We can hear, that's the basic substrate we need for speech and language development, and it's not a feature for many children, but where it is, we want to give those children the optimum ability to hear. Vision, do we need glasses? Get our vision checked, because that's going to be really important for when we're learning literacy later on. Enroll in speech therapy early in life. I'll be putting that is in the paper. Hayley's read the paper for us, early in life, to get funding to support you. Those first words can take a little bit longer, but we do get there. And sometimes people often ask, you know, well, when we're minimally verbal for a long time, should we use sign language or gesture or communication devices? All of these things are an inconvenience, aren't they? They're another, you know, thing we have to learn. They're difficult. But if it's going to take our children quite a while to get the ability to speak verbally, the evidence suggests it is great to use them if we can. And where it's also great is it lets your child keep up a bit faster with the understanding of language, which we know can also be a problem, because you're giving them tools to use language more and to understand language more. But I know that's, you know, it's a tricky area, and not all therapists are good at supporting you through use of these tools. It's a big problem in my field. We're trying to work on it. But I feel like it's something we should say, and it doesn't mean you're not going to get the verbal speech. There's no evidence to suggest if you're using gesture or a communication device that it will stop or impair your ability to speak. If anything, it suggests it will enhance your speech and language learning. It seems counterintuitive, I know, but it's what the evidence is suggesting. Important to think about sound awareness or phonological awareness tasks. So often we're so focused on getting the speech out, we forget about these tasks. What do I mean by these tasks? Okay, the word cat. What's the first sound in cat? Okay, if I take the last sound away from cat, what do I have? Just cat. Getting kids to understand how many words, how many sounds in a word, how to manipulate sounds in words. That's all really critical for their later spelling and reading, decoding, being able to sort of decode words, break words down. Rhyming, really important for sound awareness too. Reading lots of the old nursery rhymes, maybe some new nursery rhymes, making up your own rhymes. This all is metalinguistic, or teaches children broader aspects of speech development. We're so focused on getting the speech sounds out and often using a motor speech approach only. That's important too, but we need to make sure we're also bringing along literacy development, because so many of the children, they do learn to read, and that's great, and it reinforces the good speech. Speech motor impairment, intensive where you can, depending where we are, what our insurance is, what our region's ruling is for getting support. It can be really difficult, okay? But the more, it just makes sense, doesn't it? The more times you go to the gym, the fitter you'll be, the better your muscles will be, the more times you get to practice your speech therapy. The evidence suggests the quicker you will develop and acquire those speech skills. And don't stop when your speech gets to that intelligible level. There are lots of other things that speech therapists can help you with. So we see that language is very much involved. We can keep building the vocabulary, keep building understanding of grammar and the right use of words, plurals, word endings, things that are important for schooling where we might get assessed on those, and also some aspects of social development. So overall, it is very positive. Yes, the children take longer. Yes, they have real challenges. You are working so hard. Over time, we see change. And for the older children, they have gotten there. The skills keep developing. We're not seeing that plateauing. We're seeing ongoing skill development. That is really exciting and the most important message, I think, to take away. Okay, sorry, that went for a bit longer than I anticipated. Once I got going, I'm just so excited to be able to speak to everybody. Thank you very much for listening. I know that's a lot of time to listen, so thank you. And thanks again, everybody who took part. And I'm always here as a resource for anybody, or if your clinicians and speech therapists would like to reach out, I'm always happy to speak with them and reassure them, or encourage them in the approaches they might be using. Thank you.